So Philippe had made my, in fact, job much easier than I expected. But in all honesty, the way I started looking at it, first for disclosure, I'm a GYN oncologist. So, however, as I looked at this topic, I looked at it more from my hat or my position as a leader, and as a leader not only being a chairman, as a physician who is always interested to be what is best for the patient. And, you know, I'm a person who believes that we need to continue to improve what we do for our patients. So I'm a strong believer in minimally invasive surgery. I had a department where we have introduced and built and continue to develop minimally invasive surgery, whether it's laparoscopic or robotic, including different stereoscopic, different approaches and techniques. My friend and colleague, Karim Naufal here, has trained with us. So I cannot stand here with a clear conscience and say we should not be using minimally invasive surgery or more sedation for anything, and that's it, this is the end of the story. However, as I look at it from a totally different aspect. And how many of you here have heard the term stop the line? Is this something that anyone has heard? What is stop the line? So stop the line, in fact, is a term or a statement that has been developed initially in the manufacturing industry. It is developed, it's called the Toyota production industry. And Taishi Ono, who is one of the major leaders in Toyota, when Toyota was starting to pick up, when they were having problems before and they were starting to pick up, developed this of saying, in order for us to get better and provide what is perfect, we should give every single person on the line who is producing a car the ability as well as the authority to stop the line if there is a defect. And this is what he advocated at that time. And initially the managers on the Toyota floor were saying, you are crazy, because now every single person is going to start clicking the line, the cars are not going to be manufactured, we are going to have a small volume of cars, and then we are going to start losing market. And when they started implementing that stop the line kind of mentality, initially they started seeing a drop. So there were two groups of managers, one who took his word to heart and started implementing it, and another group of managers, and this is across the world, group of managers who did not do that. And initially the group of managers who implemented stop the line, they did see a decrease in productivity in the lines, but they were catching defects. They were correcting them, repairing them. So the cars were perfect. There were no recalls on the cars, versus the ones that had just status quo, historical way, the way, traditional way to do it, continued to produce more initially, but then started having defects, and they started to have to repair them down the road. And initially, eventually, everyone in Toyota stopped the line. And now it is something they teach it in manufacturing schools and in fact in business schools and management schools. And now, in fact, they started introducing it in other industry, including medicine. Stop the line. So in quality now, in quality teaching that we have in hospitals, we are introducing and implementing something stop the line. This means anyone, not only a doctor, a nurse, a student, can say if there is something that is a risk to the patient, you press a button, you stop the line. You say stop here, we need to kind of proceed. The reason I told you this story is that the story of Annie Reid was a stop the line story. And if you look at the FDA kind of statement, they did not say stop using power morcellation. What they said, discourages the use of laparoscopic power morcellation. So the FDA reacted in an emotional fashion, but they really stopped the line. And then everybody else started reacting in another emotional fashion to say, oh my God, it is the end of the world. How can we kind of do things without kind of stopping doing power morcellation? So does power morcellation have problems with it? Yes, it does. I mean, these are pictures, and Philippe has kind of showed so many data, and so many of the data that I'll show is overlapping with what he has shown. So this is not even a sarcoma. This is a picture of a leiomyoma that was morcellated, and the patient ended up with disseminated myomatosis. This is another example where we have an adenomyoma by the spleen. Patient ended up having a splenectomy. This is another example of myoma that is attached to the bowel. So yes, it does not happen frequently, but it does happen, and it necessitates other kind of procedures down the road that we do not count as part of our complications or problems as we are initially looking at laparoscopic myomectomy, power morcellation with myomectomies. These are some of the survival data. Again, Philippe has showed some of these. So this is a study from 2011 showing that patients, the green line are the patients who had no power morcellation, the blue are the one with power morcellation, and as you see, morcellation did significantly impact survival in a negative way. People who had morcellation had a worse prognosis. These are two other studies, and I'm not going to dwell into them because, again, Philippe has showed them, so I'm not going to kind of argue the point. But there is no question at the present time. We have data that sarcoma is a bad disease. We don't make it any better by spreading the tumor cells into the abdomen. So to start with, patients have a poor prognosis. Let's not make it worse, and these are what these studies show. Now, can we predict malignancy? And again, Philippe I fully agree with him. So you look at it, these are a couple of retrospective studies. We don't have a way of predicting who has a sarcoma, who does not have a sarcoma. And endometrial biopsy does not help us. Age sometimes is a little bit a discriminatory element to it. So a younger age is unlikely to be associated with a leiomyosarcoma. Older age is, but does not mean every older woman has a leiomyosarcoma. And rarely do you see leiomyosarcomas in younger patients. Can you do a biopsy? We talked about the biopsy. Can you do other testing? Well, so these are pictures I started as I was going kind of through the literature. So this is the first picture here on the left is, you see the arrows here. And if I had to look at this MRI and review it myself, I would have sworn that this is a leiomyosarcoma. Because it is, you see tumor infiltrating into the obturator fossa on that side. This turned out to be a leiomyoma with adenomyoma. The next set of pictures, the ABC in the middle, these are images, MRI images of what absolutely looked like a leiomyoma, and it turned out to be a leiomyosarcoma. And the last images on the left of the screen, or on your right of the screen, is an ultrasound on the top that was read as a leiomyoma. The patient ended up having another imaging study down there with an MRI. It turned out to be a carcinosarcoma. So the reality today, we do not have the best testing. Are things improving? Absolutely. With MRI improving, with our ability to kind of predict things, we can start to see things better. But today, when patient Reed had her imaging diagnosis, there was no way for them. She's at Harvard, so she was not at a small place. I mean, it's a place where they do a lot of studies and things like that. They could not tell that this is leiomyosarcoma. Well, this is the tissue that we get out of morcellation. And again, morcellation has its value. But the problem, it is the one patient who end up having a malignancy. These are the tumors and these are the pathology that you get to. So how good is a pathologist being able to read slides when you are looking at tissue kind of morcellated as such? Obviously, it's going to be hard. Our quest for safety, how high should we aim? So when there was an argument to say, well, the FDA overinflated the number of morcellation. Okay? So 6 sigma is another kind of term that again was used in industry and now is being introduced in healthcare. 6 sigma is a process where it says it's a continuous effort to achieve stable and predictable process results that are of vital importance to business success. Why is it important to understand it in medicine? There is nothing more important in our life than achieving 6 sigma in healthcare. Nothing more important. You know what? If my car breaks down, it's not a big issue. But if I do something on a patient that results in harm, if I don't do the right thing on the patient can die. And this is why we need to implement 6 sigma. And a 6 sigma process is one in which 99.99966% of all opportunities to produce some feature of a part are statistically expected to be free of defects. This means the defects should be 0.00034%. So this means if we are really to seek perfection, we are nowhere where we need to be. Now, this is a picture that we show in healthcare when we are looking at the harms of healthcare. So if you look here at number on the x-axis is the number of encounters, on the y-axis is the total lives lost per year. So you see that if you like to do bungee jumping or mountaineering, you have some significant risk there of kind of dying. If you are in nuclear power, look how low is your chance of being powered. So if you are in nuclear power firm, or you have a very small risk. If you are in railroads, you have very small risk of kind of dying in these. If you are driving in the US, you have a moderate risk. If you are in healthcare, if you go to get care, and this is US data, this is not, I'm not talking about Earth data, but I bet you the other data around the world might be the same or even worse. you have 1 in 600 chance of dying. The reason I'm showing you this is to say how low or how high should we aim. And when we look at sarcoma, what is the risk of sarcoma? People argued, well, the FDA kind of overinflated the numbers. Well, these are a couple of studies looking at thousands of hysterectomy, and the risk is 1 in 1,000, 1 in 200 to 1,000. It's fine. If the question is, if this is somebody I'm concerned about, is this risk high or is this low? And really, we need to kind of think about it from that aspect. And if we think it is too low, it's not a big risk, then you can say do whatever you need to do with more sedation. If on the other hand, you think this risk is high, and if you think, and since I showed you that more sedation makes survival worse, I think it's something we need to keep in mind. Did the FDA ban cause harm? So one of the other issues that came up to say, well, if we start stopping power sedation at the present time, what's going to happen? The sky is going to fall, everybody's going to go kind of revert back to open laparotomy, and people are going to have all these complications. This is absolutely right. If every single patient we treat at the present time, we take them to do on them an open procedure. As I said, I do believe in minimally invasive surgery, and I do believe that there is significant role for certain things, as Professor Descamps has said, where we need to be kind of specifically picking up the patients and using them. So we need to do this. So this is some of the data. This is a review from the Michigan Data Registry, published in 2016. The graph on the left-hand side shows you the change in laparoscopic, vaginal, and abdominal approach, and the one on the right shows you the complication rate. And if you look at it, there is no question that with the ban or discouragement, I should say, of power sedation, there have been some decrease in laparoscopic hysterectomies, but at the same time there was increase in vaginal hysterectomies and a little bit of a blip up of abdominal hysterectomies. The complication rates was slightly higher, no question. It went up by about 0.6% when you started having more open surgery. The hospital readmission was slightly higher. The hospital reoperation was not different between these two groups. This is another study that is from the National Surgical Quality Improvement Program in the United States, and this compared about 3,000 myomectomies prior to the FDA statement to 4,000 after the FDA statement. And if you look in this, they found that complications rate were not that significantly different, really, between the time before the FDA ban and after the FDA ban. So again, this kind of reflects that people started thinking. People started being more selective. People starting kind of using their kind of mind rather than everything being a nail and what they have is a hammer, and now we need to hit things on top of each other. This is what has happened with the FDA ban. And these are, again, another study looking at remorcellation techniques, electric power morcellation, manual morcellation, and manual morcellation versus mini laparotomy. And they showed that even if we give away power morcellation and we continue to do morcellation in a more controlled setting, we have good outcomes, a little bit longer surgery, but we are really getting where we need to get in these cases. The other point that the FDA brought up is to say the patient needs to be informed. We need to tell the patient what we are doing for them and what are the risks. This is a study from the Michigan group, the same group, University of Michigan, who reviewed that registry. They sent a survey to 500 patients, and this is after the FDA sent their statement. And they said, do you understand what morcellation is about? 80% of their responders were college graduates. So these are people who are educated, who read, go on the internet, look at things. They found that most women, even after the FDA ban and after everything that went in the media, did not understand what morcellation, what the risks of morcellation are. Out of patients who were considering a hysterectomy, only 12% knew what morcellation is. And out of patients who've had a hysterectomy, only 7% knew what morcellation is. And the reason I'm bringing this up, this means that we are not educating our patients well. And it is our job and our duty really to tell them what works, what does not work, what are the risks. And this is, again, something that, in my mind, the FDA statement should be a wake-up call to us. It does not mean we should stop doing it. It means that we should advocate for our patients, educate them, tell them this is what happens, this is what happens. When we have that, a huge number of patients who don't even know what morcellation is, this means we are not being transparent and fair to our patients. This is a number of kind of statements, one in the Lancet, one in New England Journal of Medicine, all of them kind of taking different approaches. And as I read all of these, all came back to the same point. What we need to do is practice medicine with really a critical mind. This is all what it is saying. It is not, again, one size fits all. We really need to kind of be selective in the way we are doing things. This is the ACOG statement. And I kind of highlighted a couple of points that ACOG in their statement, the American College of OBGYN, they said power morcellation does have a role in gynecologic surgery, that an approach that combines deliberate patient selection criteria with robust informed consent will help protect women from a negative outcome. They did not say, let's keep doing power morcellation like we've done before. They did not say stop doing power morcellation. But they are saying, let's be selective in how we are using it and what way of morcellation we need to be doing. And the AAGL kind of took a little bit for more liberal kind of approach to the morcellation, but essentially the same statement. Patient selection in the right hands by the right team is what gets the best outcome. It is not whether to stop or not stop power morcellation. So I get you back to stop the line. So I told you what stop the line when I started my talk is about in Toyota and manufacturing. This is stop the line for patient safety. And what I think has happened since the FDA kind of pushed that red button to stop the line for power morcellation, we became more creative. We have had over 50 articles, as I went through the PubMed, over 50 articles in the past 7 or 8 months regarding different ways of approaching morcellation or using contained morcellation. Philippe has shown wonderful pictures about how these things can be done, transvaginally, transabdominally, using contained morcellation. And as importantly also, we started being more cognizant of the fact that we need to educate our patients. So in our department at the present time, we do exactly the same what Philippe has kind of suggested. We do more initial evaluation, we do more contained morcellation that we have. We did not stop doing morcellation. We did not stop doing minimally invasive surgeries, but we started taking a totally different approach and more really critical and thoughtful approach to the problem. And I hope that Philippe and I did not hear that from both of us, a blah, blah, blah for the past 40 minutes. Thank you for your attention.